Okay. Good morning, everyone. Thank you very much for inviting me to participate in this excellent second conference of Search Source and OCT Angiography. Okay, now we're living in a Guga world. Have you ever heard of it? Michael, Rick? It's important to know. Things are changing very fast. What does it mean? Guga means volatile, uncertain, complex, and ambiguous. And that's the kind of world we have today. Some examples. Airbnb is leading the lodging business. Now is over Marriott in this business. Uber, they are leading the car transport in cities. They are leading this business. They are surpassing the conventional taxi. And applied to the field of ophthalmology, I would say that the same happens with OCT angiography, then slowly is surpassing the conventional fluorescent angiography. With a good common OCT, especially swift source, we can define the type of CNV. It's very well known. We can assess the presence of subretinal fluid, intraretinal fluid, pigment epithelial detachment. These are the main hallmarks to determine the need for retreatment. We can measure as well the chloride. In some cases, it's thicker. Other thinners is important as well. But the problem is that with this technology, we cannot see the vessels. And it's important to see the vessels because the vessels are the source of the fluid, of the leakage, are the origin of the problem. That's why we need an angiography. Conventional angiographies, they use dyes. In fluorescent angiography, we can determine the pattern of the CNV, the location, the size. But nowadays, with modern OCT angiography, we can assess the same without dye injection. In this case, you can see it's a very small extrafoveal type 2 CNV, and it can be very nicely assessed only with OCT angiography without dye injection. The same for ICG angiography. We know that ICG angiography is the gold standard to detect choroidal polyps, and it's very useful in many patients. But nowadays, with multimodal imaging, with the MFAS technology in some cases, and with OCT angiography, in the choriocapillaris layer, it's possible to detect the polyps as well without dye injection. With OCT angiography, we can basically determine 3 different CNV patterns. An active CNV showing intraretinal and/or subretinal fluid on BS scans, a quiescent CNV with that fluid on BS scans, and a third doubtful type of lesions with mild intraretinal fluid with a stable visual acuity. And then in these cases, it's very difficult to determine whether the lesion is active or not. In this case, probably everyone would say that it's an active case, showing some clear fluid here. This could be considered a quiescent case with no fluid. And this could be a doubtful case with mild subretinal fluid. Let's see what happens if we add some information. The similarity between the OCT, the CNV appearance seen on OCT angiography, and a dead or a leafy tree can be very helpful in some cases. Let's see an example. The same cases that we just saw before, now we are treating only based on OCT findings, treatment decision based on OCT findings. The first case, we have subretinal fluid, is an active case. The second case, no fluid. It could be considered that is not active. And the third case, it could be doubtful, with mild subretinal fluid, a stable visual acuity. The 3 patients have the same visual acuity. It's a doubtful case. Now, the same cases, based on that, please, the first case should be treated. In the second case, no treatment and perhaps a regular follow-up could be considered. And in the third case, no treatment and perhaps a shorter follow-up due to the presence of this mild subretinal fluid. Now let's move forward and let's add the information provided by OCT angiography. OCT, the same, subretinal fluid, active. Second case, no fluid, quiescent. Third case, doubtful. But if we can see here, the first case it has the appearance of an OCT as a leafy tree. It seems to be active. Then this case needs to be treated. The second case, we don't have fluid, but the leafy tree is also present. Then perhaps no treatment could be considered, but a shorter follow-up is recommended because it could be considered a risky lesion due to this leafy tree appearance on the OCTA. And in the third case, we have this mild subretinal fluid, but it's a clear dead tree. Then perhaps it's not a very risky lesion. No treatment is advisable at this moment, and regular follow-up could be recommended. Then you can see that with the additional information provided by the OCT angiography, we can change our mind when we try to decide if to treat or not some patients. On the other hand, it's important to know that the OCT angiography can show very clear neovascular complexes like this in these cases in the absence of macular fluid at any time. Therefore, the term neovascular appears to be more convenient than wet or exudative to name this disease. OCT angiography shows basically three different ways to show the CNV: the regular OCTA, the composition image, and the density map. In this patient with this active wet AMD lesion, this is the BS scan, and then we can see these different three ways of seeing the CNV. With the OCT angiography, it's very important to know where is located the slab in what layer of the retina we are. The composite image is like a projection of the different layers of the retina, and in the density map, we can see the blood flow. This is a chronic case with mild cyst in the inner retina that don't need to be treated. And it's very important to know that in patients with severe atrophy, like this case, that shows severe atrophy of the RPE, choroidal vessels should not be mixed up with choroidal new vessels. These are choroidal vessels, not choroidal new vessels. OCT angiography shows CNV changes over time following intravitreal therapy. Basically, we can see three different patterns: regression, enlargement, and recurrence. It was a patient with a type 2 CNV. After 3 injections, we can see that no fluid is present on the BS scan very nicely. And if we examine the OCT angiography and the density map, we can see a clear regression of the neovascular membrane. That is very clear seen here. A similar case, a type 2 CNV treated with 7 intravitreal injections, more follow-up, 15 months in this case. No fluid after treatment at this point on BS scan, but the problem is that with BS scan, we don't see the vessels, we don't see the source of the problem. And with the OCT angiography, at the same baseline, density map baseline, a clear regression of the neovascular complex. On the contrary, there's a poor responder to the treatment. This patient at baseline with this type 1 CNV treated with 7 intravitreal injections, and despite of that, showing more fluid after 1 year of follow-up on the macula, and a clear enlargement on the area of CNV that we can see with the OCT angiography. This is another case, the sequence of different BS scans at baseline, 6-month follow-up, 1 year follow-up. And we can see here that seems to be a recurrence at the 1 year follow-up despite following treatment. It was a case of RAP lesion. We know that with RAP lesions at baseline, we don't see normally any choroidal new vessels at the outer retina, but in this case, we see that with longer follow-up, at the 1 year follow-up, some choroidal new vessels appear at the outer retina, and this cannot be appreciated only with the BS scan. We know that with RAP lesions, for mapping the cyst, the INFAS image is very helpful, and we can map the cyst. And the appearance of the OCT angiography in the deep plexus is also very, very helpful because we can see the typical shunts that characterize the RAP lesions. This was a polypoidal lesion treated with 3 injections, no macular fluid, resolution of the pigment epithelial detachment, and here, in the choroid capillaries, we could detect the polyps with a clear regression after this treatment. Furthermore, OCT angiography can be very helpful to assess blood flow with the activation of flow mode that shows the blood flow. It allows to assess blood flow changes following treatment, following intravitreal therapy over time. This was the case, baseline, 6 months, 12 months, and here we can see very nicely that at the 6-month follow-up, there's a clear enlargement of the lesion and an increase in the signal of the blood flow that accompanies this enlargement of the lesion. And this is the reconstruction of this case with the OCT, the composite image, and the density map, then can be complementary and then can give us additional information to the average, to the regular OCTA. Another case, this patient presented at baseline a type 2 CNV. This patient developed a rip of the RPE after several treatments, and we can see very clearly that this important signal of blood flow present at baseline disappeared after treatment with a clear regression of the neovascular complex despite developing this rip of the RPE and the reconstruction of all this case. Then to sum up, we could say that OCT angiography is very helpful to monitor CNV, allowing the diagnosis of different patterns of CNV, displaying CNV in different ways, showing CNV changes over time, and helping to assess blood flow changes. Then, as Eric pointed out before in a very nicely way, angiographic examinations requiring dye injections are no longer needed in most patients. Remember that things are changing very fast. We are in a VUCA world. Welcome. Thank you very much.